Okay, so good afternoon, everyone. My name is Dr. Katie Curran, and I am an optometrist and research fellow from Queen's University, Belfast. And today I'm going to talk to you about my project, which is CHILDSTAR, and that stands for Children Living with Diabetes, See and Thrive with AI Review. So as you can see, we'll start with the images here on my screen. The images to the left just shows Dhaka, an image of Dhaka, and as you can see, it's a really densely populated country. And then the image to the right is the hospital that I worked in as part of this project. And again, I'll explain a wee bit more about that as I go on. So as we all know, diabetes is becoming a huge problem globally. It's one of the leading causes of blindness amongst working age populations. And approximately 75% of people with diabetes reside in low to middle income countries. In high income countries in particular, we generally have diabetic eye screening programs, and they can detect and treat diabetic retinopathy early to prevent any sight loss. In low to middle income countries, that becomes a bit more of a challenge just due to capacity, funding, and not having the resources available. So not only is diabetes rising rapidly worldwide amongst adults, but it's also becoming more common amongst children and adolescents. And there's approximately 1.1 million children living with diabetes worldwide, and this is continuing to rise. So the main objective of this particular project was to compare diabetic retinopathy grading performance using an AI machine with using children and young adult images in Bangladesh. So these images were captured as part of a diabetic eye screening program. And within diabetic eye screening, you will always capture from these images using a camera, as shown here. So this camera was used to screen for diabetic retinopathy, and then this is the image that was taken within the centre in Bangladesh. And all photographs that once they were taken were graded by a reference standard, and that reference standard was myself, an optometrist, and an NHS grader as well. A subset of the images were regraded by another grader, and if there was any discrepancies in the grades, then they were arbitrated by a retinal specialist. So the images were graded according to the International Clinical Diabetic Retinopathy Severity Scale. So it's really important. You can have lots of different stages of diabetic retinopathy. It can range from no diabetic retinopathy to mild, moderate, or severe. If you get to the moderate to severe stage, then generally that may require treatment or further investigation. So for this reason, we selected two different screening cutoffs. So we wanted the AI machine to be able to detect any diabetic retinopathy at all. So that could be from very mild retinopathy, but we also wanted the machine to be able to detect normal cases, making sure that they weren't over-referring. And then the second criteria was referable diabetic retinopathy. So if there was any signs of moderate or severe diabetic retinopathy, then we categorized it here in the second cutoff. And then once all the images were graded by myself and the other graders, then the results were compared with the AI machine just to see how they compared. So the AI machine that we used was developed by Orbis International, and they are a non-governmental organisation. And they were trained on adult images to screen for diabetic retinopathy. So look for normal photographs, and then also look for all the different stages of diabetic retinopathy. The AI diagnostic test performance, as I mentioned, then was compared against the reference standard, and we calculated the sensitivity, specificity, positive predictive and negative predictive values, and the area under the curve. And just briefly, I'm going to discuss some of the main results from this study. So these are some of the demographic and clinical characteristics of the participants that were included in this study. So altogether, we had 1,274 participants. We can see from any diabetic retinopathy present that according to the AI, 247 patients had some signs of diabetic retinopathy. And when that was compared the human graders, that was 212, which was 16.6%, so not a huge difference between both. And then with referable diabetic retinopathy, we can see that these numbers are a lot lower, and that's what we would expect, particularly in such a young population. We wouldn't expect to see a lot of diabetic retinopathy unless the blood sugars were really not controlled, and that can happen in cases, but typically we don't see a lot of referable diabetic retinopathy amongst young people. Then in terms of the gender, there's an equal distribution between males and females that are included in the study. And the mean age of the participants was 16.7 years. Average diabetes duration, or the mean diabetes duration, was 4.9 years. And we often find in studies and in clinical practice that if the longer you have diabetes, the more likely you are to develop diabetic retinopathy. And also, if your HbA1cs are uncontrolled, then that can also have an impact on your diabetes and the progression of diabetic retinopathy as well. So when we look at the different results from the AI compared to the reference standard, we really are interested in the sensitivity and the specificity. The sensitivity, the ability to detect the true positive. We can see here that in terms of detecting any diabetic retinopathy, the value is 75.5%. And then when you compare that to referable diabetic retinopathy, then it was 84.2%. So we want to make sure that we are able to detect referable disease and that participants or patients are being seen appropriately and being cared for if they do require treatment. In terms of specificity, we can see that the specificity is really high, and this is good. So it's over 90% in both cases, particularly for the referable diabetic retinopathy. So one of the main challenges that we have found from other studies, so very few studies have focused on children and young people's fundus images, and that's why we felt it would be really important, because there's a rise in diabetes and potentially diabetic retinopathy in the future. We really wanted to focus on children and young people's images, just to see the level of retinopathy and to see how AI could perform for the future. So one of the main differences between children and young people's fundus images and adult images is that there is typically sheen present. So in this case, we can see the top image, this is typically sheen that is present on a young person's eye. And you can see the bottom image, this is a normal fundus image with very little sheen. So we selected a random sample of participants, 289 and 97% have prominent sheen. And as I mentioned, this is a common difference between fundus photographs from young and adult patients. In previous studies, they found that with sheen, their AI machine would tend to grade signs of pathology that weren't necessarily there. So that was something that we really wanted to look into. And thankfully, we found that there were no differences, and it did not impact on the AI results. Just to conclude then, so the CyberSight AI performed well on all children and young people's images, despite the algorithm being trained on adult eyes only. The high specificity is particularly important for children, where a high percentage of images are likely to be normal, as I mentioned already. And again, the sheen was prominent across the data set, however, that didn't impact on our results too much, so we were thankful for that. AI is progressing massively globally in lots of disciplines, and particularly in diabetic retinopathy. So we're excited to see where it's going to go in the future, and hopefully future studies can focus on children and young patients' images, just so that we can train it appropriately and make sure that we're able to manage diabetic retinopathy for the future. So thank you for listening. I'm happy to take any questions, and then just finishing with the final image of the team in Bangladesh that I was fortunate enough to work with throughout my PhD and into my research post, my postdoc post as well. So thank you for listening.